on a little bit of a dreary weather outside, but hopefully the weather forecast for our opening in cardiology and the rest of the hospital looks a lot brighter, which is very nice. Just a few comments before we start. Mount Sinai Cardiology should know that they got very nice review in the Washington Post on the antithrombotic article that was published. Dr. Fuster was interviewed extensively about the impact, was cautious because it was an observational study, but talks about the impact of it, the importance of the quality of care cardiology is given, as well as future prospective studies, which will have bigger impact. Just a socioeconomic comment, there was some discussions on some of the calls yesterday about, salaries and everything. When you put into perspective what was discussed this morning, that up to 16% unemployment rate, that means 1 out of 6 people unemployed. Sinai leadership, particularly in cardiology with Dr. Fuster and Dr. Sharma, has gone really to the farthest extent, try not only to maintain employment, not only for physicians, but nurse practitioners, their assistants, the technical staff, and with trying to impact salary as little as possible, deserves tremendous recognition and commendation in this such difficult economic times, because I do think that they put people first. So I just wanted to give them an important shout out of the important work that they're doing, not only in the frontline medical, as we see recognized in the Washington Post, behind the scenes, economically. So thank you very much on behalf of all of us. Today's conference is really, I think, going to be outstanding. Dr. Lala, on behalf of heart failure, Dr. Pinney, Dr. Mancini, Dr. Moss, Dr. Mitter, have all been working very, very hard. They are one of the stellar rotations that fellows always rave about because of the quality of the teaching and the care that are given their diverse patient population and the technical difficulties. They're among the best clinicians that we have. So it's really an honor and a privilege that they're going to present today's conference. Dr. Lala has some introductory comments. Then Dr. Oliveras, Dr. Chow, and Dr. Ahmed are going to present cases. Dr. Lala?
Yeah, good morning, everyone. Thank you, Dr. Goldman and Dr. Fuster, for allowing the heart failure team to present cases that represent the array of disease we've seen on our services during the COVID-19 pandemic. I think we, along with everyone else on this call, have been humbled in more ways than one as to how this virus manifests across the populations, including our LVAD and transplant patients, in addition to seeing thrombosis, as Dr. Fuster has talked about, and then also potentially myocarditis and shock in native hearts. Over the past 6 weeks, we've formed 2 services, a condensed...
Everyone, if they're not speaking, please go on mute. It's very distracting. Thank you.
Over the past 6 weeks, we've formed 2 services, a condensed heart failure VAD and transplant service, as well as a COVID service to serve those patients who have been affected by COVID to limit cross-exposure between providers. It's really my pleasure to turn the hour over to our 3 stellar heart failure fellows, Kiran Mahmood, John Chow, and Estefania Oliveros. They've been working tirelessly through the pandemic on service, rounding on weekends, conducting research, writing up cases, in addition to doing shifts in the CCU to take care of our COVID patients. They will present to you today 3 cases that showcase the various manifestations of COVID-19 on the Advanced Heart Failure Service. We're aiming to spend approximately 10 to 12 minutes for each case presentation and then allow approximately 5 minutes for discussion and questions thereafter. We're incredibly fortunate to have Dr. Pinney and Dr. Mancini, true experts in heart failure, mechanical circulatory support, and heart transplantation, who have been wonderful leaders in general, but especially through this pandemic. And we've also asked our esteemed surgical experts and colleagues, Dr. Anwanyu, Dr. Botang, and Dr. Itagaki, to provide their perspective on these challenging cases. And I'm not sure if they are in the OR or not. But without further ado, I'll turn it over to Karen, and looking forward to some stimulating discussion. Karen?
Good morning, everyone. So as Dr. Lala said, we will start with 3 cases. The first case will be COVID-19 related cardiomyopathy and shock. The second case will be about ARDS and COVID-19 in an LVAD patient. And the third case will be a heart transplant during COVID-19. So the first case is a 34-year-old male who has fever, chest tightness, abdominal pain, nausea, vomiting, and diarrhea. He goes to an urgent care center and tests positive for SARS-CoV-2. His symptoms initially improved while he's at home, recovering from his illness, but 15 days later, they worsened and he noticed new onset lymphadenopathy. He went back to the urgent care center and he was prescribed azithromycin and cefuroxime, which he took for 2 days, but then discontinued it after developing a rash. Due to persistent fevers, he came to the hospital on day 20 after being diagnosed at the urgent care center initially and was admitted to a medicine team. His PCR from a nasal swab was negative for SARS-CoV-2 twice during the hospitalization. He had antibodies with a titer of 1 to 2880. On his second day in the hospital, his troponin increased with diffuse ST elevations on his EKG, which led to an echo. The echo showed severe biventricular dysfunction, and that is when heart failure was consulted. He has no past medical history. He is a healthcare worker with exposure to patients with COVID-19. Initially, when he was seen by the heart failure consult team, he was febrile with a temperature of 38.6, tachycardic with a heart rate of 128, his blood pressure was 108 over 57, and he was saturating 95% on room air. He was noted to be lethargic, had an elevated JVP, he was tachycardic as mentioned, and he had an S3 gallop. This is a table of his vitals and labs during his hospitalization. So hospital day 0 is when he initially presented to the hospital 20 days after being tested positive at the urgent care center, when he was febrile, tachycardic, leukopenic, and you can see his AST, ALT were slightly elevated. Hospital day 2 is when his troponin increased and we were consulted and saw him. He was still febrile, tachycardic, and we are increasing. And then hospital day 3 and 5 are after we have seen him. Between days 2 to days 3, as you can see, his AST, ALT increased significantly and then decreased afterwards. These are his inflammatory markers during that same time period. Again, you can see between hospital day 2 and 3, his CRP, LDH, ferritin rose significantly, and by hospital day 5, they were all downtrending. And his troponin, which initially prompted the echocardiogram, was 2.23 on hospital day 2, and then subsequently. Again, on hospital day 2, his BNP also increased between days 2 and 3, and then subsequently downtrended throughout his hospitalization. This was his chest x-ray on admission, which showed patchy opacities in the lower lobe, suspicious for multifocal viral pneumonia. This is a CT scan of the neck, which was done for the lymphadenopathy, which was palpable on exam. It showed multiple enlarged cervical lymph nodes, which can be seen over here, especially on the right side. Patient's EKG, which showed diffuse ST elevation, some PR depression, as well as PR elevation in AVR. This is echocardiogram that was on hospital day 2. And you can see he has severely decreased RV function as well as LV function with an EF in the 20s. So So the patient was initially given IV methylprednisolone, 125 milligrams when he was seen, and this was followed by 40 milligrams twice a day for 5 days with a subsequent taper. He appeared to be in low output and therefore was started on low-dose dobutamine. And then after starting the dobutamine 2.5, he did undergo a right heart cath, which showed an RA of 15, PA 30/21, with a mean of 24, wedge of 21, cardiac output 3.2, and index of 1.6. He also had a left heart cath, which was normal. Coronary angiogram was normal, and he had a biopsy done at that time as well. The biopsy showed no inflammatory cell infiltrates in the myocardium, and SARS-CoV-2 was not detected by tissue PCR. After the right heart cath, his dobutamine.
Please mute the phones, please. Dr. Chow, thank you.
After the right heart cath, his dobutamine was increased to 5 and a balloon pump was inserted. His PA catheter was left in place and he was admitted to the ICU. While the balloon pump was in place, he was on IV heparin for anticoagulation with an elevated D-dimer, which was later transitioned to subcutaneous low molecular rate heparin while he was in the hospital. His hemodynamics and inflammatory biomarkers improved and his lymphadenopathy resolved. His balloon pump was removed on hospital day 5 and the dobutamine was weaned off by hospital day 7. He had a repeat echocardiogram which showed significant improvement in biventricular function with normal RV function and a mildly reduced EF. He had a cardiac MRI done, which showed normal biventricular size with an LVEF and an RVEF of 52% and no significant late gadolinium enhancement. And he was discharged on hospital day 11. These are graphs of his laboratory measurements, and as you can see, his troponin and BNP peak at hospital day 2, along with his inflammatory markers, the CRP, ferritin, and LDH. The graphs look similar. So in terms of the mechanism of acute myocardial injury, we demonstrate a case here of a patient with acute myocardial injury and cardiogenic shock in a patient with antibodies against.
Bear along with us for a little time.
Yeah, put my headset on. To date, there have been no reported cases in individuals with antibodies against SARS-CoV-2. Acute myocardial injury has been described in the acute phase of COVID-19, and the mechanisms include obstructive coronary artery disease, myocarditis, microvascular thrombosis, cytokine toxicity, and stress-induced myopathy. Myocarditis there have been several case reports of myocarditis diagnosed by clinically, not with pathology. There was one case report of lymphocytic myocarditis reported from Italy, as well as another case with viral bodies on endomyocardial biopsy, but not in cardiomyocytes. We hypothesize that this acute myocardial injury in this patient was due to cytokine toxicity as his inflammatory markers increased along with his troponin and BNP in concert. And the possible mechanism for this may be antibody-dependent enhancement. And usually, normally, in antibody-mediated viral neutralization, which would be panel A over here, neutralizing antibodies bind to the receptor binding domain of the viral spike protein, as well as other domains, and that prevents virus from docking onto its entry receptor, which is the ACE2 receptor over here on the host cell membrane. In antibody-dependent enhancement, which has been described in SARS-CoV-1, non-neutralizing antibodies can bind to viral particles and facilitate viral entry and infection. And you can see that in this figure in B. And so the target cell can become infected. Another way that this may happen is called antibody-mediated immune enhancement, and that you can see in panel C. And in this, non-neutralizing antibodies bind to virus particles, which can initiate signaling to upregulate pro-inflammatory cytokines and downregulate anti-inflammatory. And we propose that this
Please put your phones on mute, please. It's very distracting. Please place your phones on mute. Dr. Chow. Thank you.
We propose that this may be a mechanism of acute myocardial injury in patients with antibodies against SARS-CoV-2, and that these antibodies may be non-neutralizing and actually cause upregulation of pro-inflammatory cytokines, leading to multi-organ dysfunction, including myocardial injury. Any questions or comments?
You know, this is Marty Goldman. Maybe you or Dr. Niebart can answer. You know, we're testing for antibodies all the time now and giving plasma. How do we know if they're going to be effective or non-effective antibodies? Is there any way of testing that in vitro?
So Marty, this is Sean. So they have done this in the past with the original SARS outbreak, where they isolated antibodies from patients with very high IgG titers, and they did in vitro assays, and they showed that they could neutralize the virus. This led to identifying donors who had antibodies that seemed particularly binding of the virus in vitro, and what they subsequently did is to take those individuals and immortalize them so that what you can do is take that B cell clone or plasma cell clone that's making antibodies of highly neutralizing antibodies, amplify that, and then collect the plasma, essentially the antibodies from those patients. So think of it like creating IVIG, but rather than pooling IVIG donors, you're taking the immunoglobulin from a specific plasma cell that's sensitized to SARS-CoV. This is what Dr. Carlos Cordo was talking about in his excellent presentation last week, which is identifying some of the SARS-CoV-2 recovered patients and finding those that are making highly neutralizing antibodies. To really answer the question, you have to do a clinical trial. And I think we are all looking to see whether or not the use of convalescent plasma translate into a clinical benefit for those patients who received it. And I know there have probably been more than 100 patients so far who have received the plasma. We'll have to see if their course is better than the patients who didn't receive convalescent plasma. Unfortunately, it's not a randomized trial. It's not a controlled trial. So there will still be some doubt as to whether or not these antibodies are truly neutralizing and can be used therapeutically. I will have to say that, until this case, I had confidence that the antibodies that were being transfused with the convalescent plasma were going to be very beneficial. But I think as this case highlights, they may actually be participating in inflammatory reaction. We've also had some internal discussions amongst ourselves and some of the cardiology fellows and others as to whether or not this might explain what we're seeing in kids with this Kawasaki-like illness, and maybe the antibodies that are present are actually participating in the inflammatory state and maybe pathoprotective.
Thank you very much.
This is Donna. I think that this case is fascinating and frightening, and I think that it is very reminiscent of the case series of the pediatric cases, which are being called pediatric multi-organ inflammatory syndrome. And I think this is the adult manifestation of that. I really am concerned that we will see more cases, and as Sean alluded to, we've already seen another 5 to 6 cases that have similar presentations.
Can I ask you about the MRI, which was unrevealing is it below the threshold for MRI to pick up, because there clearly was significant left ventricular dysfunction, which then had improved? So do we image it too late, or is it below the threshold for MRI to detect the abnormality?
Can I answer that? This is Gina LaRocca. Good morning. Great case presentation. As far as imaging, we should at least see some edema. If we don't see at least edema, there's really no inflammatory cells within the myocardium. If we're getting too early, we should still see something on T2 wave imaging. And later on with late GAD and seeping of the gadolinium in the myocardium. So MRI is pretty good for this. I'm not sure if we really missed the timing of it. T2, you'll have T2 before late gadolinium.
Martin, I would like to make a comment because it's very interesting. This reminds me in parallel with what is happening with the new immune pharmacology for cancer, where in fact you have, one of the problems is a cytokine reaction that actually causes exactly what was presented this morning. There was a paper in JACC actually about 3-4 weeks ago, in which there are changes in the myocardium. There is this decrease in function, myocardial dysfunction, and then it returns to as normal. And certainly in that case, in the cancer patients, this is considered to be a cytokine reaction that causes injury to the myocardium. So I guess my take of this case is that the damage, at least the damage that we see transiently, is cytokine release, and that how the antibodies and all that, where they come from, I can only tell you in the cancer patients, it comes from macrophages when it is done with immunopharmacological. And what is being found now at autopsy in these patients who are COVID positives is lots of macrophages are not in the tissue specimens that you do, the lung, etc., are in the bone marrow. So my take of the case, at least, is very much in parallel to what is seen with immunopharmacological treatment of cancer, with transient ventricular dysfunction, increasing troponins, and so forth in some cases. So it's just a comment. The antibodies may be involved, but where the cytokines come from, to me, is a critical issue. But to me, could be possible.
I agree, Dr. Fuster, Jagat Narula here, absolutely, because myocardium here has been untouched other than the fact that the cytokines themselves are causing some kind of a biochemical effect on the myocardium, because they did the endomyocardial biopsy, showed no inflammation. They did they have seen the T2s, they have seen T1, there has been no abnormality, there is no late gadolinium enhancement. So essentially it is a kind of a cytotoxic, not cytotoxic, it is a cytodepressive effect of the cytokines. As we very well know that even IL-6, simple as that, in the beginning is protective, but later can become myocardial depressive. So it could be a depressive effect, depressor effect of that. So, and then one day effect was there, transiently it was seen, and the next day everything came back. So what you are saying, Dr. Fuster, that probably is the best explanation of the pathophysiologic process, because once the COVID-2 has become negative on a swab, and the antibodies with that kind of a titer are present, it does not look as much possible and then in the children, it is altogether a different pathophysiology as compared to what we are seeing here.
Thank you. Are there any thoughts?
Why do you say that? Why do you say that it's totally different, Dr. Narula, in the kids?
The reason I say that is that it is more of an endothelial involvement there in the children.
But in this particular case, that in comparison to that new entity that's being described, how is this really different? Because the kids had diarrhea, they had rashes, they had LFT abnormalities, they had myocardial dysfunction, which is all what this young man unfortunately had.
There's viral antigen is gone here. That is the problem. It is 20 days later with such an antibody titer. I don't believe that that can really happen the way you are thinking as compared to the children.
Donna, can I ask you or Dr. Fuster, do you think this leads to any insights into unique therapeutic options for patients like this?
Well, in patients with, I'm talking about cancer, I keep going back to a different disease, but certainly corticosteroids have been used and some other medications have been used in this type of patients, yes? And I think these patients receive corticosteroids, if I recall.
Yes.
But this has been done also in cancer patients with the so-called cytokine syndrome.
So this is Sean. Just to echo Dr. Fuster's comments, that's absolutely correct. With CAR T therapy, what you see are high levels of IL-6, and that can create this inflammatory response, lymphadenopathy, extremely high fevers. If it wasn't for the use of tocilizumab early on in the CAR T experience, CAR T therapy wouldn't exist anymore because patients would have died from this inflammatory reaction. So it's interesting too that in this particular case, the one cytokine that you saw significantly elevated was IL-6. TNF alpha levels didn't really go up very much. It was really all driven by IL-6. So in this case, if we had the IL-6 value early on, we could have used tocilizumab. This would have been a case where tocilizumab would have been effective, or sarilumab, either one. But it also responds very well to corticosteroids, and I think that's why this patient recovered so quickly.
I agree with you, Sean, completely. Did you do IL-1 also, by the way?
I don't remember. Kieran, do you know, did we look at IL-1?
Yes, we did.
And was that elevated too, or no?
It's right here, IL-1 beta, IL-6, IL-8, and TNF alpha.
Okay, so IL-1 was normal.
And this is the pattern for the other 5 or 6 patients that we had who present similarly, and the IL-1 was normal.
Yeah, because yesterday there was a Lancet paper, as you might have seen, where even the canakinumab was effective in some of the patients with COVID-2. So here in this case, IL-1 is normal, and it's only the IL-6, which is IL-6 and IL-8 also.
And Kieran, can I ask you, did his antibody go down by discharge, or was he still? Did he still have very elevated antibodies to COVID?
We did not repeat antibodies prior to discharge. We did repeat his inflammatory markers, and the IL-6, 8, TNF alpha all decreased significantly, close to normal.
Don't you think we should repeat his antibodies, especially if we're postulating that they may be a mechanistic factor for his cytokine storm?
Yes, we're planning to repeat them once he comes back.
Okay, this is Anu. This is a great case. I was just in the interest of time, I want to move on to case 2 so we can allow everyone to present.
Good morning, everyone. Thank you for the opportunity to present. My name is John. I'm one of the heart failure fellows. So our next case is a patient who's on LVAD support who developed severe ARDS in the setting of COVID-19. So our patient was a 70-year-old male who had a destination therapy HeartMate 3 LVAD that was implanted in 2016. He developed fever, flank pain, and hematuria. So he went to a local emergency room for evaluation of nephrolithiasis and as well as urinary tract infection. They did a CT scan of his abdomen pelvis, which incidentally found that he had atypical or viral pneumonia. His abdomen pelvis portion was normal. At that time, the local ED tested him for SARS-CoV-2 PCR, but he left AMA before the testing resulted. When we spoke to him over the phone to gather for more information, he did mention that 3 to 4 days before his symptom onset, he did attend a party locally. Over the next several days, he had continued to have fevers, as well as new symptoms of cough and dyspnea. And at that point, he returned to our ED at Mount Sinai Hospital. Initially, when we saw him in the emergency room, he was febrile at 38.5 Celsius. He was tachypnic, and he was relatively hypoxic on room air, requiring oxygens. His JVP was estimated around 8 to 10 centimeters of water. He did have crackles, mostly on the right side, more than the left side of lung field. Other infectious etiologies that we look for usually are driveline sites, and his driveline was clean, dry. He was warm, and he did have mild pitting edema. We proceeded to test him for SARS-CoV-2, and it was positive. And we called the ED near where he first presented, and that was also positive too. We did interrogate his LVAD parameters, and I will spend a few minutes talking more about it, since this will be important later on. As you can see here is his sample illustration of an LVAD monitor display that you usually see in the hospital. The speed, the pump speed is what we set the patient at, usually from 5,000 to 6,000 RPM. His was 5,600. And using the LVAD would have to generate a certain amount of pump power to maintain that speed. And his pump power usually is around 4.4, I'm sorry. And then using the equation that the HeartMate 3 has, it can generate a estimation of pump flow that's going through the LVAD, as you can see here. And his is around 4.7. On the previous heart catheterizations that we did at baseline to optimize the LVAD, the flow through the LVAD is similar to the cardiac output that we measure. And then we can see the pulsatility index here, which is kind of the LVAD estimation of pump flow through diastole and systole. We also can look at the alarms through history to see if he has any alarm that are significant. And he had really nothing that is very much. So this is his chest imagings. On the right side is his X-ray, and showing that he has significant infiltrates on the right side more than left, which is similar to what he did initially too. So he was hypoxic using high flow nasal cannula up to 70% FiO2 on his first few days here. And by day 2, he was intubated with a very PF ratio of 80 and severe ARDS. We did give him tocilizumab to reduce the inflammatory biomarker profiles too. And that improved a little bit in terms of inflammatory markers. However, his clinical condition progressed further in the next few days, and he died from PA arrest on hospital day 8. Here are his biomarker profiles. As you can see, he has severe ARDS based off of the PF ratio. His VAD flow did decrease significantly throughout the clinical course. And his inflammatory biomarkers were elevated, and at hospital day 6, it was greater than 3,000. So things to consider during in LVAD patients in the setting of COVID-19 as well as ARDS on vent settings. All these patients has increased biomarkers such as LDH and relatively CRP because of their underlying LVAD support. So we should look at more percent change in terms of LVH and ferritin as we have these markers as baseline. The second thing that we should look for is RV failure in these patients because the LVAD really truly support the left side of the heart rather than the right side. So we should continue to monitor JVP and as well as CVP through a central venous line monitoring. We should be more mindful of PEEP management so that way we can be careful to induce RV failure. And on a daily basis, we should look for any other additional support such as inotropes as well as inhaled nitric oxide. Furthermore, we can also look at LVAD parameters on the monitor display in order to estimate whatever the cardiac output is, as I said, using the flow. And then if you can see speed drops like from baseline, that can signify whether the patient has suction events from left-sided hypovolemia. And then the other thing we have to consider is that in patients with propensity toward infections, as our patient here, whether a modulator is beneficial in terms of long-term effects and inducing more infections. And then interestingly, he died, an outpatient died of cardiac arrest in the setting of having MCS. The last question that we had was whether we can prone these patients too. In prone ventilations anyway, it can also cause this alpha graft internal traveling compressions, hardware placement that are malpositions, and then they can also impact on the RV hemodynamics and also anxiety for staff. Here's a summary of what we consider. Any questions and comments?
Dr. Ani, you're on the phone. Can you give your thoughts on the case, please?
I wasn't actually actively involved in the case, so I don't have any comments.
Marty, this is Sean. So John, thank you for that presentation. I think for what we learned from this case was that even patients with LVADs are not protected. We thought that if we could just support him and support the right ventricle and give his lungs time to recover, that he would actually make it through this. And we had a little bit of optimism early on in his course by about hospital day 4 when his PF ratio began to improve. We were also weaning down some of his inotropic compressor support at that time, and we actually thought that he was going to be protected from the LVAD and he would be a survivor. And then just the bottom dropped out, and around hospital day 7 or 8, he had refractory hypotension, refractory to increasing doses of norepinephrine, and ultimately died of, a PEA arrest with an inability to maintain any blood pressure or perfusion. So this was a case early on in our experience. This was at a time before social distancing and isolation. The party that he went to was his own birthday party, which we told him not to do. And their concern was that he ended up infecting about 50 other people. So just to put a little spin on the story. But I think the take-home message here is that in the setting of a severe inflammatory reaction, and coupled with significant hypoxia, the right heart goes down, and the LVAD can only pump what the right ventricle gives to it. So in the setting of vasodilation, right ventricular failure, severe hypoxia, we lost this patient.
Yeah, I think it was just intractable vasoplegia. and right heart failure. And it was really upsetting what happened with him socially, and his dismissal of the initial warnings from the other hospital when he was in the ER and he left AMA.
Maybe in the
Eric
interest
Stern here. I had a question in terms of the mechanism for vasoplegia. I didn't have a chance to ask at the prior patient as well. One should not, I think, dismiss a biochemical kind of thing, totally unrelated to this. But if you had, for example, very low phosphate, you have no energy stores, things don't work. But MRI product doesn't look like much. There's no infiltrate. So just something to keep in mind in terms of mechanisms, that they aren't necessarily cellular. So that's my only thought here.
Dr. Fuster, any questions? Thank you. These two great cases. Thank you both. Dr. Lala?
Yeah, thank you so much, John. We're going to move on to the third case. I think there's room for some very interesting ethical considerations here. So I'm going to turn it over to Stefania.
Hi, good morning, everyone.
Can you speak a little louder? Speak a little louder, please.
Of course. The next case is a 47-year-old with end-stage ischemic cardiomyopathy that was initially admitted with ventricular tachycardia. He was transferred from an outside hospital in VT Storm. He underwent initially a VT ablation, but he continued to have ventricular tachycardia and progressive shock, requiring mechanical support with an axillary intra-aortic balloon pump and very high doses of pressors. He was listed for transplant on February 28th. He underwent heart transplantation on the 11th. It's important to mention that the first reported case for COVID was on the 1st, and the New York on pause started on the 22nd. So these represented some barriers later on with transplantation and like assessment of patients. Post-op hospital course, he underwent week 1 and week 2 right heart cath and biopsy. Initially, we have not been screening for COVID as it was not required by an institution, as we were getting to know how the pandemic would affect the care of our patients. He had normal allograft function on echocardiogram, and he was actually able to be discharged on the 14th day post-op. He was left with standard immunosuppression regimen on tacrolimus, CellCept, and prednisone, and standard prophylaxis for opportunistic infections. At discharge, he started having symptoms on 4/11, a few days, like a week, 2 weeks after he was discharged. He was having fevers, headaches, and for about 3 days. He had undergone his surveillance biopsies the weeks before, and without any symptoms prior. Then on week 5, he continued to follow up with us with telehealth visits, as we had been doing for the majority of our heart failure patients. And his symptoms actually had improved. He had no GI complaints, no respiratory symptoms, and normal vital signs. And he was just advised to stay in quarantine and comply with hygiene measures. No one at home was at that point. Then on the week 6 of biopsy, he actually tested positive for COVID in one of the routine pre-procedure screening that we started to do in our patients prior to undergoing surveillance biopsies. He, at that point, continued to have no symptoms, but the right heart cath and biopsies were done on the negative pressure cath lab room. At that point, we decided to actually switch the type of surveillance that we were doing, and doing, instead of the biopsies, doing cell-free DNA, AlloSure, which actually was negative and normal. And we also checked for AlloMap, but the results are still pending for that. His chest imaging was done when he came with a COVID positive, just to screen to see if there was any infiltration of pneumonia. But as you can see, there's nothing remarkable in this x-ray. The inflammatory markers were checked. This was when he, on the 22nd, was when he was diagnosed with COVID for the screening biopsy. His inflammatory markers were elevated on the 22nd and 29th, same as the LDH that was 261 to 256. D-dimers were slightly elevated, as well as his ferritin. He never had troponin, no elevation of lactic acid, and 1 week after, 7 days after the initial positive testing with PCR, he had antibodies, 1 to 160. So in this case, we had a transplant patient that had benign clinical course. We just kept doing the standard immunosuppression and surveillance as well. The patient was feeling well without any need for hospitalization, and thankfully no rejection complications. I just wanted to mention what has happened to the adult heart transplantation, especially in the Northeast. As you can see here in this graph to the left, on February 1st is when the first case was reported in the New York area. And then on the 22nd is when we started doing the isolation, and New York was placed on pause. And you can see a steady decline in the number of transplants performed in the area. On the slide on the right side, you can see what happened to the wait list. So in green, you will see how people were putting in the wait list for transplantation. And then the spike on blue is how many patients were actually inactivated due to COVID precautions in the area. The number of transplants as well had decreased, and we still need to see what this will mean for our patients. The considerations for transplantation in COVID area, we have divided them in 3 stages. Pre-transplant, the questions are who is remaining on the transplant list. So we left people active that were in status 1, 2, and 3, but it's always a shared decision-making process because the patient has to be agreeable as well to be transplanted during COVID when there's so many unknowns. During transplantation, procurement, probably the surgical team can comment on this. Some of the centers had requested the surgeons to bring their own PPE and limited amount of staff that can go to procure the organs. Some centers had actually not been, did not want New York staff to come to their centers. And one of the important things is that we're starting to test the donors and the recipients the day of transplant. Post-transplantation, the management of immunosuppression. In this case, it was a mild case, so we did not adjust immunosuppression. We continued to do surveillance biopsies, but for other of our patients that have been for a longer period of time after transplantation, we had switched them to AlloSure and AlloMap, which does not require the biopsy part, but allows us to do molecular diagnosis in them. Televisit is one of the key parts and has played a big role in our patient population because it allows us to make sure that they're okay, since we cannot have so close contacts in hospital visits. So these are the pre-transplant considerations, rejection surveillance, and post-transplant care. This slide basically summarizes how we are dividing our management. There's always going to be in pre-transplant the risk-benefit ratio consideration for resource allocation. You have to weigh in who is really sick, who has a higher risk of dying because of COVID or because of not having appropriate mechanical or transplantation. And the other points were already discussed in the prior slide. Then rejection surveillance, we usually screen for fever, cough, dyspnea, and GI symptoms for patients that are undergoing biopsy, and appropriate use of PPE. Post-transplant care also has been interesting because we have to monitor immunosuppression levels. So we rely on mobile phlebotomy and laboratory monitoring. We have to also take into account that the caregivers that are with our immunosuppressed patients have to also be screened for COVID-19 symptoms. And we have to support our patients through proper home hygiene and adequate home support. Thank you so much.
Thank you, Steph. I have a couple of questions and a comment. One thing is that we have to all remember that transplant is a life-saving operation. It is an emergency, and as such, even in the pandemic, it was allowed to go forward. In terms of this particular patient, I don't remember the donor and the recipient if they were tested for COVID at the time of the transplant.
They were not. At the beginning, we were not doing that.
Okay. So we don't really know whether this infection was transmitted from the donor. It could conceivably have been from the donor.
So in the initial screening that we had, he was screened at this point in week 1. So yeah, right. We did not screen until week 6.
Thanks, Steph, so much. This is Anu. I was wondering if Dr. Anwanyu or one of our surgical colleagues could comment. I think they've provided some really good insight as to some of the surgical considerations surrounding transplantation during COVID.
I know most of the considerations are around the procurement process, ensuring the safety of the recipient, and also the logistics for providing the transplant. I think the logistics was the most difficult because at different times we haven't had access to operating rooms, intensive care beds, and also the necessary staff to do the transplant. I think one just has to assess the logistics of what resources one has and whether one can do the transplant. The very last transplant we did was nursed on 7 West, which is not ideal. And the other thing that goes into consideration is selecting the patients and recipients, because in a pandemic, you don't have the resources, for example, to take care of a patient who needs a lot of perioperative care. So a patient who we think would end up on ECMO or with a severe graft dysfunction, we would tend to avoid those because we don't have the ability to take care of a patient on ECMO on 7 West, for example, or a patient who needs to go have an open chest. It would be very, very difficult. The procurement has been touched upon, and the real concern is surgical teams, procurement teams being vectors for transmission of the COVID, either from the host hospital to the donor hospital or vice versa. A lot of centers have stopped traveling, so would rely on local teams to do the procurement, but even at then, there's still somebody moving the organ from A to B. So by and large in New York, most transplantation has stopped for the last 4 or 5 weeks because nobody's coming into New York to procure organs and no one is leaving. In terms of testing the donor and recipient, initially we didn't have on-site testing, but now we have on-site testing in most donor and recipient facilities. So almost all donors are getting tested, and certainly at Mount Sinai, all recipients are getting tested.
So thank you very much. It was a great presentation. This is Maria. Just one observation. I don't think we have looked for the antibody titers in this group of patients, or maybe we did, but I think it would be nice to also do a prospective assessment of, what is their antibody response and whether or not it correlates at all with the outcome that we are seeing.
This is Sumit. I think it's a really good point, Maria. I want to echo some of the comments that Dr. Mancini made that, transplant is a life-saving operation. We've actually performed around 5 transplants, I believe, during this COVID pandemic. And while this one patient did develop COVID, we're not sure when it actually occurred. It could have been transmitted from a donor potentially. We have been able to successfully manage thus far a number of patients with transplant during the pandemic. But as Maria said, we should really be looking potentially at antibody titers to see if there's some kind of varying response that our fresh transplant recipients have.
Can I ask either any of the heart failure experts to comment on whether the immunosuppression may expose people to greater risk of infection, but it may inhibit the cytokine storm? So is it a double-edged risk, but in some way protective of that massive cytokine storm that we had seen in the other patient?
You know, that's one theory, that the presence of immunosuppression may decrease the severity of the COVID illness. You know, the New York State Transplant Consortium has been collecting data on the transplants in New York State. And if you look at the number of heart transplant patients who were infected, there's probably around 75 statewide. And the mortality in that group, the gross mortality in that group is around 10 to 15%. So they don't really look like they're protected.
Are you going to look to see to change any of the immunosuppressive therapy in the light of the risk of COVID, you know, currently and moving forward?
Well, our approach has been not to change anything unless the patient becomes infected with the virus. At that time, what we do is decrease the anti-proliferative drug if they're on it. But we have not proactively changed immunosuppression in these patients.
Dr. Fuster? Anu, do you want to make some comments, or any other heart failure team, any closing comments on these three excellent cases? I want to commend the fellows on really wonderful cases. Any comments?
Thanks so much. I just wanted to give an opportunity to Dr. Pinney if he had any closing comments on transplantation during this pandemic.
We're all very much looking forward to returning back to the normal or a new normal. We have a number of patients who are deserving of transplant, and our concern is that the number of donor referrals have precipitously dropped locally, almost to zero for solid organ transplant donors. And now that there isn't as much of a demand for ventilators throughout the region, maybe some of the donor hospitals will be able to donors and be able to make those donor referrals so that we can resume heart transplantation. We also have to be sensitive to the fact that, as Dr. Anyanu said, that our donor recovery teams are considered as vectors of the SARS-CoV-2 coming from New York. And so most of the donor hospitals outside the New York region will not allow our donor teams to enter the operating room out of fear of us infecting them. So I think it'll still be a few more weeks before transplantation returns back to the pre-COVID numbers. We've been very proactive in terms of who we are willing to transplant. I think once we see the return of donors, once again, we'll jumpstart our transplant program.
Thank you, Dr. Pinney. Thank you, Dr. Goldman, Dr. Fuster, and to the rest of the cardiology faculty and fellows for allowing the heart failure team to present these cases that represented sort of the spectrum of what we've been seeing during this pandemic. I hope everyone stays safe, and feel free to reach out with any questions offline.
That was great, Anu. Thank you very much for putting it together, and for the wonderful heart transplant physicians and nurse practitioners and associates who've really kept a very at-risk population safe. So thank you very much for a great presentation. Everyone have a nice weekend. Thank you very much.